We're all sitting in a hospital in a setting where we're committed to providing service delivery and health, and there's always this additional tension to actually provide evidence of what we do, why we do, and how we do it, and how research integrates with that. Today I'm going to talk about some examples, and I had the opportunity about 5 or 6 years ago I predominantly was a teacher, so I've spent most of my time doing teaching, so the academic track record in research was probably not as prolific as other full-time researchers. But what would happen is that I then left one university and I came back to Curtin University, and my appointment there was 50% at a hospital and 50% as an academic. And I realised very quickly that those years and years of doing research only, I needed to actually do something which meant something to clinicians. So today, my ambition is to actually describe that you need to do research in health services and systems to actually free up opportunities to invent, innovate, and even get funding towards better optimal care. And so getting it done is really what it's all about. And I'll give an example that someone once said to me, research that isn't published isn't done. I think the world now is research that isn't disseminated isn't done. So you may be able to change your clinical practice, and if once you show that something's working in terms of healthcare, then clearly people tend to pick it up. And I've had people come to me about 3 or 4 years after we sort of did a pilot program, and they say, oh no, this is how it's always been done. So the world changes faster than any publication happens if it's effective for the users. So you've seen this. I heard the health minister talk, and he spoke about the accessibility, quality and affordability, and that's where you need to go. I don't know if you feel isolated or not, but guess what? That's what's happening in most Western healthcare services. At universities, we have 3 elements. We have internationalisation, we have education and research, and in the process of deregulation, those 3 core business elements are being brought together, not being separated out. In healthcare services, research into health systems and primary healthcare is actually being integrated. So things are coming closer together when under pressure, not being separated out. So I'm going to try to talk about a few aspects of that today. So it's about taking and making opportunities. We all know that health research does not happen in a void. Health research occurs across a spectrum of activities and methods. And so it's knowing where you sit in this continuum is important, but you need to look to your left and to right and see how those innovations are impacting on your behaviours. It is an integrated network. Today I'm going to discuss how health systems research is critical for the future of both discovery research and translational research. And those people who the word translational research is a big time in Australia. I don't know in Singapore, but everyone's talking about it. I'm not sure how many people are doing it or how they're packaging what they're currently doing into the concept of translation, but it's pretty important. I'm going to talk a bit about blue sky and red and blue ocean strategies to understand that if you're going to do health systems research, you need to step out of your comfort zone and have ideas. And I always say to people, I tend to make decisions at the university, back of my mind, I don't say it out loud. If this was a company, would I be buying shares in it? Okay, so if this is such a good idea, would you be willing to put skin in the game? And that suddenly rationalises everyone's thoughts. Well, actually, probably not. Let's move on. So I'm going to talk about that in the context. So what's blue sky science? Well, this is from Wikipedia, so it's not my definition, but blue sky science is scientific research, is a domain of research where the real world application isn't immediate obvious. Now, you're going to invent Wi-Fi or, Apple computers or something like that. That's blue sky science. We probably don't do a lot of that in a place where there's not a lot of money to be thrown around in the laissez-faire method. However, something like that is fundamental for step change innovation, and we recognise it. And it's characterised by freelancing, what-if questions, really what we'd say left field, innovation, never thought of that. And the classic would be from Perth, would be Barry Marshall's use of antibiotics for ulcers and led to the Nobel Prize. That was a completely paradigm-shifting, disruptive technology concept. And so this is blue sky. Blue sky science or research doesn't have quarterly reports. The middle management doesn't get down and control them, right? There's no KPIs. There's no stop-go milestone decisions. I'm on boards and we have this all the time. It's all about control and management and continuous improvement and performance. Blue sky people don't have that. However, what is interesting is that we need a mix of this well-controlled, process-driven research, and we need a bit of innovation, a bit of excitement. Now, the interesting thing is that what mix should it be? Now, if we thought about Christopher Columbus, right, he wasn't told that he had to stick within 50 kilometres of the coast and only head north or south, right? Basically, he was given a huge amount of resource and went blue sky, go for it, and found America. And so, this is what it's all about. And so we still have to value that. Now, as a middle manager, what I do is that I ask researchers, and they all want to be Christopher Columbus, right? They all want to get the money and stop asking me questions, So real life is that that's not the case. So what we have to understand is that there is a link between strategy and the execution of that strategy. And people judge a strategy based on the outcomes, but often if it's not executed well, it doesn't mean that the strategy is wrong. In health science research, in health systems research, we have to make sure that we undertake appropriate strategies and we commit to that strategy to try and execute it as best as we can. And if we've executed it well, then we actually can judge whether the strategic methods has been approached appropriately. So where does the research funds come from? Now in Australia, health costs are rising dramatically. I suspect exactly the same in Singapore with the ageing, with the increase in middle class, increase in expectations, in a more patient-centred domain. People have a larger voice, and I think that's very important. But the sustainable and accessible and optimal research which underpins healthcare is really important. So today I'm going to try to talk about some of that. One problem is about execution. It's very easy to execute a strategy if you have a blank check, right? Because you just do it and everyone's happy. But in the world of refined resources, we see it's like a balloon, and if you squeeze one part, the other part will grow. And so there is an internal competition amongst therapists and allied health and doctors of different disciplines to arm wrestle for different types of resources. So we have to understand that it's a zero-sum game. Some people argue that it's probably less. So health costs are rising faster than the actual investment in health. So the amount of money is being squeezed, and there is an internal competition. This internal competition is good in many aspects, but not very good if it turns into a competitive market, which isn't consistent with the strategy. So let's talk as an aside for all those people in private practice or business. This is something for you to think about. So blue ocean strategy is a simple concept from a book in 2005 which spoke about the ocean of companies is blood, full of blood. It's a red ocean. And so companies are competing against each other and it's a feeding frenzy of different sharks and whatever. I'm not saying that hospitals are a bit like that, but I'm sure many people are feeling a bit under pressure trying to apply for a small grant to get something done, and it's competitive, etc. So what we need to do is understand philosophically that we need to move, right? And this movement is about creating opportunities to actually improve those strategies, which is accessibility, quality, right? And really looking at the delivery of the service. And so when we're talking about that, there are 4 principles. I'm only going to put this up so you get the idea of where we're going to come from when we do our research projects. The first principle is we need to reconstruct the market boundaries to create uncontested opportunities. Now, if that's in private practice or in business, you understand that. But in healthcare, we have to understand that our internal competition is as negative, right, against the opportunities to change the market. So in allied health, there's occupational therapy, physiotherapy, podiatry, diets, and they all have their own scope of practice. And there's a bit of tension when things switch between systems. So we've got to make sure that we have uncontested opportunities really to focus on the big picture, to improve health and the health delivery in optimal and accessible and quality. So we look at the big picture, and this is our common strategy that we look at. Right? So at my university, we have this ambition of becoming research intensive. Right? We want to improve our research activity and excellence. And that is our single big picture. And we execute activities to achieve those goals. We let the people decide how they make that execution strategy. It's not down at the top down, but we also make it very clear that this is our ambition. And so you need to actually be consistent, your behaviours need to be consistent with this ambition of the big picture. You need to redefine your existing or your consumer demands. Now that means how much inpatient activity can be done in outpatients, how much outpatient activity can be done in primary health care. So we need to understand what the consumer demands are and how we can change the public health to actually, or their attitude to their own health, to actually improve health service delivery. And finally, you need to have a sequence of strategic agendas to understand that everyone's on the same message. The dilemma with healthcare, and particularly in hospitals, is that relative to demand, the resources are a zero-sum game. In fact, it's probably a diminishing, but we won't talk about that. So although there's more money going in, there's more money being spent. And so let's say it's zero-sum. That means if there's a loss, if someone wins, gets a new thingatron in the lab, someone else didn't get something. And so we need to work together strategically to understand that. So let's talk about translational research. Biomedical sciences in Australia gets about 2/3 of all health funding in medical and health in NHMRC grants. And that's because there's discovery science. You know, we really do want someone to make a big step change into research in the area of managing MS, stroke, diabetes, cancer, the big ones, right? However, we need to actually translate, and you would have heard many stories how it takes 17 years to get things done, etc., in terms of translation. In Australia, we have fields of research which align to certain professions, and we can see that there's more of a biosciences into molecular microbiology, pharmaceutical sciences, the more cognitive sciences and TMS, and then you go right through into public policy, population health, etc. I put these up because these are some of the fields of research in Australia. I don't know if you have similar fields, but I suspect it's just a continuum. When we're talking about translation, we talk about, there's all different models, and here's one that I've taken off somewhere, and it's basic science, discovery, and then we move into an early translation with selected cohorts or small samples. We go later, so we're looking at replication studies, very important replication studies, the number of randomised controlled trials which people have an invested interest in seeing it work, always has a huge effect, and then everyone else tries to replicate it, and it's about half the effect size. And that happens regularly because it's a whole belief system on how things are working. And then what we need to do is disseminate that into practice and then really get government and systems to adopt it through policy. And we can see this translational model. Everyone in the room would have heard about this, and this is not you, and you're sitting there going, here we go again. What I want to point out is that translational health research has to be consistent with the institutional governance on feedback and feed-forward systems. Now, invariably, when everyone talks about translation, we go from left to right. There's actually an arrowhead here suggesting that everything travels in that direction. What we need is really an understanding that this is an iteration. This is a feed-forward, feedback system, and clinicians and clients and the government who's funding it need to have a voice. Otherwise, they will be a top-down and say, you will do this. So we need an interaction where clearly we have this feed-forward strategy. So basic scientists are informing early transition, they're informing later, and then in dissemination and maybe adoption. But in fact, if we want a legitimate stakeholders approach, we need the feedback to also happen. And this is the cultural change that is happening, hopefully, as we're trying to manage our resources. Now, people in the discovery sciences are very stressed about this because they perceive, they don't want to be told that a clinician thinks that we should be studying this, right? But it's a little bit more sophisticated than that, but they do actually have to have stakeholder engagement. Advocacy of the government or the policymakers or the public health people need to come back into the early trials to actually see how that works. So that's the first major brain change that we have to understand what we're doing. And therefore it won't be competitive, it's actually interactive. And of course what we do, and I've got another thing here, in the top left we see public policy influencing medical microbiology, not medical microbiology influencing public policy only. It's interactive. And so a lot of healthcare systems, MSRA, screening, that's public policy versus this, or say HIV or antibiotic resistance. This is an example where we need to actually have an interaction between the discoveries and epidemiology working backwards and forwards. But this should happen in all areas. In all areas of healthcare, models of care, we should have some integration of innovation in terms of that. And so in Western Australia, I'm on a government board which has a tiny amount of money, a few $1 million a year, but it's on translational research. It's called the State Health Research Advisory Council. And they are looking at translational systems to fund within hospitals to optimise healthcare. And there's this continuing argument saying that's not real research, right, because we're trying to save money or treat more patients with the same amount of money. However, that's because people are going from left to right on the translation. We need to have it coming back as well as feed forward. So I'm going to give some examples now. And these are just recent examples. They're completely biased because I'm the author on all of them. Not all of them are very good. And so I'm just going to raise a couple things. So there's 4 areas. First of all, length of stay. Length of stay is a very interesting phenomenon because everyone's trying to reduce length of stay by maintaining outcomes. We looked at some knee and hip replacement length of stay modelling. The reason for that, I've got that as number 1 because I validated what we did in Western Australia in Singapore General Hospital, so I'm here to say thank you. Secondly, we're looking at clinical prediction rules. So we've done a couple of clinical prediction rules about whether someone who has a lower limb amputation uses their prosthesis or not. Believe it or not, 20% stop using it within the first 12 months. And also outcomes in radiculopathy. So cervical radiculopathy, who is going to be a good likely candidate of being a good responder to surgical intervention or conservative intervention. Then something completely left field is a running program for neurological injury. It's not really running, right? We don't put them on a track and make them run. But it is a dynamic rehab program, and we'll show that. And then finally, this is a bit of a passion that we've done, is local health care systems for spinal cord injury and physical activity. So hopefully you'll see that I've gone through quite a variety. And there's a burns. I did some burns work as well. It's somewhere there. So let's go through it. Here is the RPAT. So it's the tool which people use at interview just before surgery for knee replacement or hip replacement, and there are 6 questions. You don't even have to ask some of them because it's gender and age of the first 2, but how far can you walk, which gait aid do you use, 0, 1 or 2, do you use community supports, and will there be someone living at home when you get discharged? Pretty simple, do it over the phone. We were able to demonstrate that in a group of approximately, I think it was about 300 people, I'm not sure, we had hip and knee, left and right sides all balanced. 5 to 7 days was the median time. Now, when this scale was developed, that was developed in 2000, and the average length of stay in Australia was somewhere between 9 and 13 days. Right? So to think that such a scale, and this was designed to work out who would be sent to a rehab hospital and who would be sent home. But now with the integrated healthcare, we don't have rehab hospitals. It's all done in one. And everyone goes home or to where they came from. And so we tested the validity of this scale into a new system when the length of stay is much shorter. And what happened is that we were able to see that it was between 5 and 6 days median for length of stay. I suspect it's now 4 and 5 because this is 3 years old, 4 years old. Things are changing. I think the message here is that if you're doing systems research, you have to understand that it's the system that you're changing, not trying to predict the length of stay. The length of stay changes. And so what we were able to show that this scale, very simple scale, was able to identify high risk of people staying longer than the rest of the cohort, and low risk people who are likely to leave earlier than the average cohort. And the good news is that we were able to validate this in Singapore, where the length of stay was slightly shorter. And we're in the process of validating it in Japan. Who can guess what the length of stay is in Japan for knee replacements? Anybody want to guess? Anyone? This is the interaction part. If I said 25 days, would you be shocked? 35 for hip. Now, we have to look at their system, because their system is about full rehab, right? They have onsens in their hospitals, so, you don't want to particularly want to leave, right? So and that's how the system works. But any predictive model is about understanding the system. And so I'm sure if they could reduce it from 35 days to 25 days, woohoo, right? So there's a system is a benefit. So you have to understand that when you're doing systems change, you have to have what they call organisational self-similarity. So what you observe in the culture in one department, is that culture replicated in the faculty, and is that replicated in the organisation? Because if you see it at different scales in the organisation, it is a cultural issue. And going down and giving the single person right at the bottom a hard time because they're not following the rules isn't going to help, right? They'll leave or you'll lose your job because the system hasn't changed. So let's go on. Here we have high, middle and low risk. So people scored, and you can see there's a bit of a trend. The people with the high risk tend to stay a little bit longer, and the low risk a little bit earlier discharge. In the box plot, you can see that people who scored a high risk, so a score of less than 6 out of 12 on that simple test, are 2 times more likely to be in the last quartile of the length of stay. And the people who were low, so a high score on the test, they were 2.3 times less likely to stay an extended time. So the trick is that, so what? Well, what this means is that when you're looking at length of stay in Australia and it's 5 days, surgeons only work on certain days, and we don't have a lot of care over the weekend. So you can actually, from this risk, you actually allocate the person to not be discharged on the Saturday or the Sunday, because guess what? They get discharged on the Monday, because that's how it is. So just with this simple thing, we can allocate in 3 weeks' time when their surgery is, they're either on the Thursday or the Tuesday, and we saved a bucket of money, right, just on that simple understanding of how people are allocated. Now, did we save a lot of money? Well, we could have, but patients are allocated to particular surgeons. So irrespective of their risk score, they will always have the surgery on that day because of the surgeon. So this is a systems failure, and you have to always look at that. But the good news is it was validated in Singapore, and although Singapore is a completely different model in terms of success on outcomes, much more efficient than where we were working, the predictors are the same. It is still effective, and I'd like to thank my co-author and any other co-authors who are in the room, so thank you very much, on demonstrating that this is a valid predictive tool which can be done over the phone in less than 30 seconds. So, stratifications of clients to optimise models of care. That's the systems objective of looking at screening tools. Do you have a clinical pathway which you come to a point where you can send to one model of care versus another model of care, rather than just standardising a single model of care, which some people do well and some people don't do so well. So I suggest that you think about these screening methods to optimise your care. This leads to clinical prediction rules. A clinical prediction rule is a set of simple rules used by clinicians, right? And we use it to stratify the likelihood of a responder and non-responder into a standard model of care. In Western society, there was the period, what I call, of the RCT. If you're going to do evidence-based practice, everyone wanted to do an RCT, right? Anyone who does multimodal interventions, you've got to have $1 million to do an RCT, right? Because basically, and I joke, and this isn't going to go very well in Singapore, right? You get the world's best treatment in Australia, so you get everything thrown at you if you have spinal cord injury or whatever, or low back pain, and then that's the control group, and the intervention group is all of that plus Vegemite, right? Test the effective of Vegemite on whatever, something add-on. Now, the multimodal interventions, the current best practice versus current best practice plus something, right, is a very difficult research project to do. And you have to have huge sample sizes to try to detect the differences. Suddenly it becomes a multi-centre trial and the millions of dollars spent to actually get that done. What we're doing now is to say, well, let's just take a breath about the evidence-based practice and let's say, look, I know on average that our delivery is doing quite well. They get better. But I do know some people do really well and some people not so. It would be good if I knew at the beginning who was going to do really well. No matter how hard we work, they're still going to be fine. And others, no matter how hard we work, they're not going to be fine. Is there a different way? So this is a stratification model and really valuable in systems change, and doing the old balloon where you can squeeze one part and give more resources to another part, and both groups actually have successful outcomes. So just as an example, so we did some predicting respondent models to treatment, and we looked at this to decide if there is a valid way of detecting who are going to be responders and non-responders. That's not 100% accurate, but some of our models are increased likelihood ratio of 16, right? 16 times more likely to be a responder than not. That's getting pretty good on the clinical relevance. Two areas, just very quickly, predicting outcomes, the cervical radiculopathy following surgery and following conservative at 3 and 12 months, and the 4, 6 and 12 months use of a prosthesis. Here are the 3 factors which we found for surgical outcome following cervical radiculopathy. Younger people do well, right? That's good. Under 40, I consider from my point of view, that's young. The pain and disability scale, so they don't have a huge amount of pain and disability, so that's good. You know, remember, they're still having spinal surgery, right? So it's not that they're fine. And they have the head-neck angle, right? It's 40 degrees. This actually had a likelihood ratio. If you had these 3 things, a likelihood ratio of 10 to be a responder to the surgical outcomes. At 12 months, that's at 3 months. At 12 months, there's different factors. People who have had the symptoms for a long time actually respond quite well to the surgical. They, once again, don't have extreme pain and disability. Once again, the neck flexion is, if it's reduced, then they tend to have a better outcome with surgery. And rotation to the right just happens to be to the right. Left is just similar, but it's correlates of great. So when they've got good rotation and not much flexion, they respond quite well to surgery. There are reasons why these numbers come up. It's mostly statistical, but it's a screening tool. It's not a impairment measure of why, oh, well, that's the key, you know, I'm going to improve their flexion and they won't have to have surgery. It doesn't work like that, okay? So this is a marker. Here's an example of why are we doing this. Here's predictors of non-use of prosthesis. People who have their lose their lower limb, and we're not generally talking in Australia about people with being bitten by sharks, some people might think so, or playing with chainsaws. It's mostly with systemic disease, right? So peripheral vascular disease, diabetes, etc. Here is two prospective cohorts, or retrospective and prospective cohort of non-use. The percentage of people who spend all this time in rehab and they stop using their prosthesis, you can see that about 8%, now 1 in 12, never use their prosthesis. They get discharged from hospital after all of this rehab that the physios do. I told them that and they were distraught. All of that work that they did, and 1 in 12 just put it against the wall. They've never used it. But it gradually declines, and they spend months and months in rehab learning to walk with a prosthesis, etc. So we were interested in if we could identify these people, and we were able to show that basically at 4 and 6 months people stop using their prosthesis, and 8 months, and at 12 months here are the critical factors. We recently published this out, so don't really try to interpret what the predictive variables are. We had literally 40 or 50 different predictive variables. The good news is that creating a clinical prediction rule is easy because it's a statistical process, but testing it on another cohort, that's when you really find out. And so we were able to validate this, and this is quite an effective predictive model in our health system, that if people use a walking aid after rehab, if it's above knee, then this is a risk factor, and all of these are significant. The question is, so what? And the systems change is that we know that the 5-year mortality rate of this cohort is approximately 50 to 60%. Right? So half of them will die within the next 5 years. Do we really want to spend 3 months doing rehab for them, and then when they realise they can't do any walking, etc., we then put the OTs and engineers in to put ramps in their house, and that takes a year, etc. Why don't we start this off straight away in terms of actually optimising and a patient-centred model of care? So we start identifying people who are less likely, and I just want to ask the bottom line. I pull them aside and say, are you going to wear this prosthesis? No. But they're engaged in the enthusiasm of everybody in the healthcare services, and so therefore they participate in the rehab, and it's months of rehab, etc. And the outcome is that we want to see what's best for them, what's their outcome. And so this is why we use these predictive models. Let's very quickly, I'm going to spend another 5 or 6 minutes, running and high-level mobility following acquired brain injury. Gavin Williams has done a lot of wonderful work with young males with following trauma, acquired brain injury, mostly motor vehicle accidents, and he gets them back to literally running and doing high-level mobility. We used that and we brought it into the outpatients for neurology, average age of 60, 65. And we did a randomised controlled trial. So we've been working on this from about 2007, and we're now rolling it out with the Cerebral Palsy Association. So we're doing a clinical trial to see if this works. Just as a basic argument, rehab is a long journey. Starts with a single step, but sometimes you might have to get on with it and start running. So this is what we always present to our rehab people. If you're interested in high-level mobility, you need to have these higher ambitions. And so we started off with a randomised controlled trial. We ran that in outpatients, and here's the translational model. What I did then is that I'm a sports physio, although I do all my research, I get all my money in neuro, but I love sports physiotherapy. And so we now do quite a lot of research looking at tendinopathy in athletes and bouncing them on sleighs and everything, and doing all this fancy mathematics to see that people with Achilles tendinopathy run with an increased degree of ankle stiffness. And the eccentric loading reduces that stiffness and breaks this nasty cycle, but that's another talk. What we did is that from the randomised controlled trial, that was an early translation, we actually got some funding and we went into the hospitals and we rolled it out to 5 different hospitals, rural hospitals, and 1 metropolitan hospital, and now we're rolling it into Cerebral Palsy Association. And so this running program is about a philosophy of actually being a much more aggressive program of therapy, and it's a group program. and which has always stressed people. And so we did a randomised controlled trial and we compared outpatients, a group with a running group. Outpatients was one-on-one twice a week for about an hour, hour and a half each session, and the group was once a week for about 2 hours. In the group there was anywhere between 6 and 8 people, and so the therapists were a bit stressed about that. You know, group training versus one-on-one. Remember, the outcome was high-level mobility, and we found there was no differences. They all improved. A couple of and I've got some raw data, but basically they all improved. All the differences were clinically meaningful. There was only a couple of, let me repeat that, not all, the average value was clinical meaningful. Some were responders, some were not. So if we had a bigger population, we could look at that. But it was positive. And what we found was the cost index. So this is when the efficacy is exactly the same, but we noticed that if you have 2 hours a week with 8 people versus twice a week for 90 minutes, one-on-one, you can see where the cost issue is. So basically, here's the 95% confidence interval of the cost index. The cost index is the number of points improvement in the HIMAT score, which is a high-level measurement tool. And we see that outpatients, you spend a lot of money to get 2 points improvement, and the same amount of money gets approximately 12 times, right, the points. Now, that stresses the outpatient physiotherapists. But in our world, they're being told that they only have a certain number of treatments per client. And so I said, think about this. If you're given 6 treatments one-on-one, you realise you can have 4 treatments one-on-one plus 6 weeks of a running program for the same cost. So it's about utilisation of resources. Remember that balloon, right? We're squeezing the one-on-one, but every time we lose 1 session of one-on-one, we can pick up 6 sessions of running program. And so this is how systems analysis works. Some people would be apprehensive going, oh, well, that's it, I'll lose my one-on-one therapy time. And you go, no, not at all. We need to actually think of the balloon, squeeze one with a big increase in the other side. So we were able to roll that out and show that it was feasible in different hospitals. Interestingly, without a large outpatient throughput, we didn't have large groups in the running program. So as soon as it gets down to 2 or 3 people in the group, you start losing your cost effectiveness. So there are systems where you have to maintain the numbers. And so I'm just going to skip through. We did a burns analysis for outpatients. This is a couple of works with the Fiona Wood group, very well-known burns research. We were able to show that people with minor burns tended not to come back for the follow-up visits, and these do not arrives or did not attend cost money. And so we did a whole analysis demonstrating that, first of all, our assessment tool was sensitive. Secondly, if we gave people a self-directed workbook and a risk management, if these things happen, contact us immediately, we were able to show that they were able to not have to turn up. There was high levels of satisfaction of the users. It was a new model of care. We were able to save 1 clinical appointment. People go, so what? That's actually a big saving in time and staffing, and it proves the efficiency and also reduces the patient burden. Some people have to have half a day off work to come in just to say, yep, that's looking good, see you later. So we were able to show that. So this is a very important thing, and this is a model of care change. It was driven by the therapists, not the researchers. So Vidya, the first author, did a master's project with me and ended up getting funding from it from the health department because we did a cost analysis saying, let's prove that this works. And so this is one of the strategies that needs to be done by therapists. It was part of her job, and she just ordered it and then got a statistician to look at the system change. Once again, that balloon, we were able to squeeze one end, and she was able to get time to do more work on the people who would actually turn up. So finally, finishing up was this concept of food miles. So food miles is a term that refers to the distance food is brought to transport by the time you eat it. And so it's a sort of a sustainable model of health, etc. Sorry, of food, food security, etc. And it's probably not correct, but it was at least a philosophy of trying to eat local. And what I thought is that I think for healthcare to be sustainable, we need to have more of a primary healthcare model. And I did some work with spinal cord injury years ago. And so what we did is that, what about health miles? Health miles is zero when someone with primary healthcare, right, receives primary healthcare in their home. And so can we deliver primary healthcare by the local community, for the community, people living in the community? And this is where people get very interested, because all the universities and all the health systems go, yeah, fantastic, let's get out there and I'll get another $1 million. And I'm saying, no, this is not an institutional-based thing. This is a primary health care in the community. So physical activity of people who have spinal cord injury is problematic. The amount of physical activity, leisure time physical activity of someone who lives at home with a spinal cord injury is really minimal. You see a lot of the high-profile wheelchair athletes, and we certainly have them, and the Paralympics, they do really well. But there is also a cohort of people that sit at home and basically do zero, right? So the evidence suggests about 4 minutes a week, right, is the 25th percentile, and the 50th percentile is about 3 minutes a day of leisure time activity per week. So about 21 to 28 minutes in a week. So that was Canadian data, but we think that's about the same. So I thought, well, let's do this as a project. This is part of a larger project led by Mary Galea and Sarah Dunlop and myself and about 9 other researchers across Australia and New Zealand. It was about a $5 million project called Skipper. But this was one program that I ran, which was the Skipper Com, or Skipper Community. Skipper isn't just about the Skippy, thing. It's spinal cord injury physical activity. That stands for. And so we're interested, and we looked at the barriers. And what were the barriers of someone sitting at home in a wheelchair going, oh, I don't want to work out in the gym, and all the barriers that all middle-aged men have. I don't look good in Lycra, right? No one knows, and thank God. No one knows anything about spinal cord injury. I'm sick and tired of going to the hospital. I'd like to go to my local gymnasium, but no one there knows what to do, etc., etc. We also looked at the barriers of people in gyms. They don't want to, when someone wheels in a wheelchair, a lot of them go, well, I'm not comfortable about this. So we actually did a whole program of community-based program. Our model was train the trainers. We engaged with local gymnasium and community councils. A lot of the gymnasiums have a community basis where their values say we will offer services to everybody in the community. And so therefore they were quite happy to engage with us to try to get people in wheelchairs into the community gymnasiums. We engaged with fitness trainers. Note, not all the research, but the vast majority of research on spinal cord injury rehab is either run by health departments or services, or the community-based gyms are always the university gymnasium of, right? So it's always linked to students or other therapies. So there's all these inputs from other services to try to keep it going. What we did is that we just rang up gyms and said, do you know anyone in your department as a fitness trainer would like to train someone with spinal cord injury? Right? That's a bit scary. We said, look, we will provide training. We have a website. You do that, you do a few assignments, we'll come in and we'll give you a one-day workshop, and then we will match you up with someone who lives within 3 kilometres of your gym. And we did that, and we had about 50 trainers train, and then what we did is that we contacted people with spinal cord injury, said, look, have you ever thought of doing this? And if they put their hand up and we were able to geographically match them, local with local, they participated. And so we had 37 gymnasiums around Australia and New Zealand participate. And without giving too much away, we taught the trainers, we taught them how to manage risk, how to break down their personal barriers, both internally, their personal opinions, plus externally, make sure the door's open for wheelchairs, etc. They thought we were going to teach them how to do exercises. So I'm quite well known for core stability, and every fitness trainer wants to know about core stability, right? So, let's get him to talk. I never mentioned it, and I'm sure they were disappointed. But getting in there to change their attitudes, and about 2/3 of them still do this work now, and it's worked out really well. And the PhD student passed, and she's writing up her work now. The highest scores ever. I've had a lot of PhD students. I've never seen the reports back from the examiners, so that was fantastic. Here's two examples. This is the raw data. These are box plots. On the left-hand side, you have people who are inactive. Now, if you look at the baseline, the median is at 0 minutes, right? So it's a pretty easy way to improve. This is minutes of leisure time physical activity, self-reported on a valid scale. And after the 10 weeks of one-on-one, they were able to increase it to about 50 minutes of leisure time activity. That's a big change. We didn't have any money to have any other inputs. So as soon as the money ran out, and most of this was done on volunteer basis in the gyms, so they got free membership or the $5 a visit or something, they dropped back down. But it's much higher than what it was statistically, and their physical activity levels actually were maintained at 9 months, which is remarkable. Now, the other half, with people who are active, they're doing an hour of formal training or physical activity a week. So these people didn't change, which is fine by me, right? Because they're physically active already. They're above what is required to have this huge risk of cardiovascular disease decrease. So we targeted the appropriate group. Generally, and I've worked in spinal cord injury for quite a while, it's the ones circled in the green who are the ones that you see at conferences, presentations. These are the ones who are really, really keen and volunteer for research, etc., and they do everything. The one in the reds, they're sitting at home and they're hidden within the community. So this is a systems change for local healthcare that we've done, and we think that the road trauma, one of the insurance companies is going to actually back this, because in one of the states in Australia. And so we're quite excited about this train the trainers concept, and we think this would work for people with on dialysis or etc., all the different areas. And one thing is that a third, and Australia is very urbanised, a third of our delivery was in the rural settings. It's independent because it's local, right? You might as well be, as long as you're within 2 or 3 kilometres of the gymnasium, that is local. We didn't care. So people in Cairns, Canberra, wherever. It was all over Australia, and it was done by internet risk management. So research systems change is complex. You really have to have the attitude to take it on. It's not easy. You've seen some of the work that we've done. Most of this is through Royal Perth Hospital, so it is integrated with staff. I've picked up quite a lot of senior therapists to do PhDs and masters. They get 1 day a week for their research, often. Sometimes we get a bit of funding to pay them out for some of their research activity, but the key is that their 1 day research is engaged in their clinical practice. They don't do 4 days work doing something on burns and then try to do research on muscle profiling in spinal cord injury. The burns researcher does their practice in burns, and they answer a question that they're passionate about in burns. So we match their ambition with their job, and that's good for their promotion. They write papers about it, etc. So when we're talking about collaborations and alliances, and I'm going to go through this quickly, a lot of partnerships break down very quickly, and this is the book out of The Strongest Link. 60-75% of alliances break down. If you're a therapist and you want to do research, you're going to have to talk to your line manager and create an alliance with a common vision. This is fundamental for you to be successful. Just doing it by yourself won't work, or the manager telling you what to do, managers, that won't work either, right? It has to be work together. So you have to have a strategic fit. You have to negotiate win-win. What's in it for me? What's in it for you? Are we both happy with that? Secondly, you have to align your organisational ambition at multiple levels. And you have to work together to look at productivity. So basically, you want to make sure that you have a common vision on how you really want to change the health system. So seeking a common vision is about transparency and trust, which goes up the organisational structure and down the organisational structure. It's got to be both ways, right? This is not a cottage industry, right? Cottage industries work like this. I want to improve my salary by 20%, I've got to see 20% more people, clients. It doesn't work like that. Universities and healthcare are billion-dollar businesses. We need to actually leverage our productivity and really think about what the value is in terms of accessibility and quality for healthcare. And I really like this idea, and this is just off the internet, your bacon and eggs. Right? It's good to be the chicken, right? But if you're committed, then you're in there with the bacon. And to be honest, some of the people I've worked with, and I've got names here, most of these people are the bacon type of people. They're committed, right? And a lot of them are committed to actually, their heartfelt, intense focus is to try to improve the outcomes of the service that they provide, because that's what makes them come to work every day. It's not getting the PhD or paper. In fact, a lot of these people haven't written papers, which is very disappointing for me as an academic, but they have changed practice. So with that, I think if you have a common vision, and if the person's paying the bill is saying that it has to be accessible, quality and affordability, in the race of life, the favourite doesn't always win, but that's who you should put your money on. And so if this is what your minister is saying, what needs to be done, then if you have a plan to do some health systems research, then your strategic vision needs to be in one of those three domains. And you just got to work out how you can execute it to make sure that you're successful. So thank you very much.